Hello, my name is Kåre Nielsen. I am the organizer of the Barral Institute in Denmark. I'm also a Barral Institute teacher. I'm a physio and an osteopath. I'm here now today to talk a little bit about the uh, neuromanipulation, or the first class within the neuromanipulation program, neuromeningeal manipulation, NM1. Um, So the neuromeningeal manipulation is really to understand the topography and the function of the nervous system, and eventually then to manually evaluate and treat. So that is a lot of understanding of where the nervous system is within the cranium, within the brain, and coming down through the spinal canal and out of the different plexi and into the peripheral system. Our first class that we have, NM1, has the index here. I have printed out so that you can see what is the content of the class. So there is a lot of theory on whiplash and to understand the different forces that may happen with trauma. So that gives you an understanding of what could potentially happen to the nervous system. So yes, when we talk about trauma, of course, it's not only the nervous system that will be affected, but also anything around the rest of the part of the body. So if you have a trauma to the head, of course, it's the cranium, but there could be something happening in the neck or into the thorax as well. If you had something coming from the side, it could be happening to the ribs and to the viscera, but eventually also have an effect onto the nervous system. What we're focusing on into the neuromanipulation program is the nervous system. What would the trauma then affect here? So we have to talk a little bit about some theory on what are the physics of trauma and the stress deformation relationships, and what is energy and what is impulse, and how does trauma react into the body. But I have highlighted a few things just in white, so that these are the things that I will speak a little bit about today. So we can have a few things from this class that I can show you a little bit about. But you can see also, apart from the theory, we have something about the cranium itself, something in the craniofacial junction, so into the front, and something into the backside in the cranium, the spinal dura, down towards the connection of the neck to the dura and the tentorium inside the cranium, and further down through the spinal canal down to the pelvis. And after that, we will consider the plexi from going into the arm or going into the leg. And sum everything up in a protocol so that we can know how to evaluate the nervous system from an overview. So I'll speak a little bit about the first part, the cranial part. First of all, we do talk about some concepts. We do talk about some ways that we can be influenced with trauma, some whiplashes, and how would we in detail understand a whiplash. So if we're sitting in a car, motor vehicle accident, and there's a hit from behind, what happens into the body? With the force coming onto the seat, we're being pushed forward in our lumbar area and into the sacrum, and the head will be slung back, sort of. So the snapping back of the head, we have the center of gravity pushed forward. But then after that, we're being released and whipped forward with the head heading towards the steering wheel, and like a whip. But in the same time, our center of gravity will go down, and the sacrum will pushed back into our two ilii. So in detail, we will look into what happens in the body and how does that actually affect the nervous system. Also, we have a different way of a trauma coming from the side. So we can imagine now that something happening to the side of the body, or if you, for instance, are falling down, or you lose your footing and you land onto the side of the body, that would affect into a side bending. So if we look only at the nervous system, yes, that would affect the nervous system as well. Here's an image of the spinal cord and of the brain and the uh, cranial membranes you can see as well with the uh, dura mater and the tentorium cerebelli. So with that side bending you can see on the right side of the image, that will then shorten the right side and lengthen the left side. So that has a massive effect onto the membranous system and onto the tentorium. So we will evaluate also the cranial dura, so the membranes of the skull, and the spinal dura, then to see how they interact with each other. Yes, this is the nervous system we speak about, but with the side contact, we could also have a great effect onto the ribs or onto the pleura or into the heart itself. Uh, the trauma tends to follow the harder places in the body, so tends to be certain areas of the bony system that it will follow and certain viscera. So we talk about the heart being a particular firm structure in relationship to other parts of the viscera. So it will follow the axis of the heart down towards the left, often if there's a trauma inside the thorax. So that may affect down more towards the left kidney, more towards the spleen. But in a side situation like this, it could be hitting more onto the ribs. So often in clinic, you have people coming and they have falling down on the side, and they think they've hurt their hip and they have strain of the hip and situations, and maybe it is something broken. But that could be just bruised ribs that has the effect to the pleura, to the diaphragm, down towards the psoas, and towards the kidney and following down to the femoral nerve and into the front thigh and down into the knee. So it could be a succession of a pain pattern coming from a hit onto the rib. But in this class, NM1, we speak a little bit more about the nervous system. So what happens into the dural tension, like you can see here, that once you have a side bending, whatever effect there is in the rest of the body, there's a side bending in the membranous system. So a shortening on the side of the impact and a lengthening on the other side. So that tightens up also the tentorium on the opposite side. We do have different forces landing into the system, whether it's a external and internal force. The internal ones we call stresses. So there's, in principle, three different kinds of stresses that we can have, where we can be stretched or compressed, or it can be a shearing. This is actually the same as we're working onto the body with our hands, that we can stretch or we can compress or we can make shearing into the system. So those components we will use as we treat. Of course, we have a primary component that we will use, but there's also a secondary or in what we call in stacking in the Barral Institute, so we can put also the rotation and another part of the axial compression or a horizontal or a shearing situation as well. If we speak about the skull and then the content of the skull, we can look at the skull as a whole unit, but we can also look into different parts of the bony construct. We see, of course, that there are lines. So we have sutures of the skull, and each of them potentially can be stuck. So we have the bony hardness of the bone itself, but we also have the suture that we can evaluate. We can evaluate bone hardness. Is there a extra impact into the bone itself, so that is hard, or is there some suture that is blocked? And that could be any suture within the system of the cranium. So we can see in the upper part the coronal suture and the sagittal suture, but below at the bottom of the cranium, there's a lot of small sutures that can be compressed in the cranial base. We have some reinforced areas of the skull, ridges that tends to be where the force may follow when we hit onto the skull, so any cranial trauma. So they are following in this direction here. So if there is an impact to the head, it follows the hardness of the skull. If we take it step by step, coming through the skin into the gallia, then we have the bone. And underneath the bone, you have the lining of the cranium, the membranous system. So you can see in this image here, underneath the bone, like the swim hat of the brain, you could say, that is glued up against the bone, totally connected to that, has a little small trabecula keeping it there. And then underneath there, you have the sinuses. You can see here the sagittal sinus. And then next step is the arachnoid trabeculae. You can see what you cannot see here in this image is the pura mater. Pura mater is like the swim hat, but vacuumed, sucked in around the edge of the gyra. So that's all within every little crease of the brain that you can see, but you cannot see it from this image. That's also connective tissue. So we have connective tissue as a strong dural membrane and little trabeculae, the arachnoid, and then you have the pura mater in the deep. That very, very subtle connective tissue that you may also train your hands to feel. So for us as manual therapists, we're trying to find this texture and the feel of each of these levels. We're trying to also teach you in NM1 how to feel that and how to differentiate between the different layers. So here's another image of the sinus, sagittal sinus, and you can see the dura mater on the left image and the deeper layer in towards the brain on the right. Here's an image of lifting up that cranial dura. So you can have an imagine of the swim hat. I do remember one time I had a dissection, I was with a dissection class, and this dura mater, as you can see here, was totally stuck up against the cranial bone, the cranial vault. So I had the enthusiasm to wanting to take off the cranial vault, got myself a saw, and you can see where the cranium is taken off here is pretty much where I was sawing all the way around the cranium to take off that callot of bone. But it was very difficult because the dura was totally stuck up against it with the little sharpy fibers. So it's scratching, finally coming off. But I was tearing off dura as well. So it was stuck up against the bone. Underneath the dura, you can see a little bit the pia mater, the arachnoid first of all, but the pia is not so easy to see. So the dura mater is also connected to the falx and the tentorium. Falx being the one that separates the two hemispheres, a very strong connective tissue that is coming from the front to the back. At the back end, it has kind of a slope going down to the tentorium out towards the temporal area. And then the falx continues underneath. So we have a cerebral room, but we also have a cerebellar room underneath. But this is a very strong membrane that has at the top part little room for sinuses for the venous system. We will be able to feel that strong force as we're entering into the skull with our texture feel. Also able to evaluate, is it more the forks going from front to back, or is it more the tentorium going out to the side towards the temporal area? Within this class is what we are training to do. If we look at from the top down, we're taking the brain out of the skull and we're seeing the surface at the base of the cranium. Now we can see on the left side the cerebrum room and below the cerebellar room, but also the innervation of all of these membranes are part of the cranial nerves. So each part of the membranous system has relationship to cranial nerves. So this is very important for us later on. In the beginning, in M1, we discuss a little more the membranous system, some more fascial feel. But once we get on to the NM4, we discuss the details of each of these nerves so we can have an effect to the membranous system from a neural component. Also, we will see in this NM4 class, the anal nerve coming from the back, going up the gallia to meet the trigeminal nerve coming from the front, as you can see in the other image. Inside the brain, we have the ventricular system. This is a nice image of the left first ventricle. We have the other one on the other side, and we have the third and the fourth ventricles further down. This is where they have the liquor system or the cerebrospinal fluid. This will come from the brain and empty out into the venous system. You can see on the other image where the granules will then have the cerebrospinal fluid coming into the venous system, where we will talk about how to drain also the brain. So this is the venous system. We have within the sagittal suture coming down towards the sigmoid and out into the jugular vein. You can see as a big pipe underneath the brain, on the cranium here. Then of course you have the brain itself. So the green part is the frontal part of the brain, and the yellow is the parietal, and the blue is the temporal, and in the back they have the occipital part. And if we look on the inside and the central part, we have more the limbic system. One of the biggest things that we have in the Barral Institute that is different from other manual therapy organizations and osteopathic studies is the listening. The listening is what we use to find where to treat. So we're looking much more for the cause rather than to jumping after symptoms. Of course, we take it as a general situation, so we also have a general listening. So we take the whole body, we're feeling down through the head in the standing position to feel where in the body, where is the most important part of the body. With that, we may find that the head then is the most important part that we need to look at. And then we are looking into a local listening of the head to find what is the most important here locally. And then we can be even more precise with the differential listening. But this is to show maybe the listening locally on the head. So here we are looking to feel, first of all, what is within the sphere of the whole head? Where do we feel the most important part? And then we're trying to find what kind of texture it is. Maybe is it on the right side, more to the front, to the back? what's the depth of what we feel? And then what is the texture? What is the feel of it? Because as I was just explaining through the different layers, the bone, the suture, the membrane, and finally the brain, it has different texture qualities that we want to feel for. So we're feeling first, and then we're thinking later. We also actually do have witnesses, so we can check to see then which kind of structure it may be. First of all, is it a initially hard stop, right? So that's more bony feel, right? Or if it's slowly coming over and then becoming a little harder, and that might be then the suture. But finally, if it's more slow, progressive stop, that's more membranous. That can take you then around the inside of the skull, or inside in the middle to the falx, or down the slope of the tentorium. So this is what we will be practicing to feel the different qualities. The final one is the one that goes on the inside to a softer jellyfish fish type of feel. So we do have a protocol. This also shows you a little bit about what you may see in the NM1 class. So of course we have that general listening to feel the entire body, to have the where. And then we have the local listening to determine what exactly is it that we're dealing with. In this case, the cranium, then what level are we on? And then we can check the witnesses to see the frontal bone is what tells us, is it a bony restriction? So we can feel in the frontal bone if there is a bony restriction in the rest of the cranium. Then we can check the coronal suture as a witness. That will have a restriction if there's any suture that has a restriction. And finally, the sagittal suture, we can test to see if there is a membranous system. So that will have a restriction if there is some kind of membranous system problem. So that gives us a possibility to be more clear and to verify what it is that we feel, the level and the texture that we feel within the cranium. So if there is an anterior listening, that might be something in the face because we're going towards the visceral cranium. And so that could be within the junction between the frontal bone and the base of the nose. So we have specific techniques to evaluate the frontal part of the cranium. It could be a posterior listening. And then we are looking into more the base of the cranium and the relationship down towards the spinal dura. So the occipital temporal relationship, potentially out to the side. Also, it could be with the tentorium. So we have a possibility to evaluate the whole cranium and to have an idea then what to do, because we have specific techniques for each of these areas, whether it's more anteriorly for the junction to the face, whether it's more posteriorly into the cranial base, and the myodual bridge that we have, or whether it's going down towards the spine, how to then evaluate the relationship of the spinal canal with the dura running down through the spinal canal. So I spoke a little bit about the witnesses. So we have the cranial hold that we will have below for our local listening of the head, and onto the three witnesses we're feeling for elasticity of the bone for the frontal, and for the coronal feel more of the sutural restriction. So that has not a totally hard stop, but a little bit movement, and then is a firmer stop. But the membranous again is a slow progressive stop onto that part of the membrane. Again, it can be around the inside of the cranium, or it could be inside in the center towards the falx, or perhaps put a little more posteriorly sloping down and around towards the temple area. So within the program, we have a core pack. I spoke a little bit now today about NM1, and of course, there's more to that. There's a detailed program with a lot of things for you to learn. We also have NM1, 2, and 3, and 4. So 2, we go more into the peripheral system, talking more about the arm. And 3, we're more into the leg, where NM4, we're more back into the cranium to look into the cranial nerve. So a quick rundown of the index of these 3 classes. We talk about details of the peripheral nerve to understand how are we able to be in touch with the peripheral nerve, right? So as it coming out of for the NM2, the area of the brachial plexus, how can we then be in touch with the nerve itself? What kind of pressure do we need to be in touch with the nerve? So without compressing it, because the nerve does not like compression. It likes elongation. You can almost imagine that when you see the picture above here, where the small tubes of the nerves are within another tube, embedded within another tube, why they potentially can glide within each of these little tubes, with the perineuron, within the endoneuron, within the epineuron. So elongation is what we will need for them to be functional. So you need elongation to be able to move your arm. If you are not, if you don't have the possibility for an elongation, you won't be able to move that arm or the leg for that matter. So it's necessary for us to have that elongation. It is also how we treat it. We get in contact and we invite it for elongation. So NM2 is about the nerves going into the arm, with the cervical plexus, the brachial plexus, coming into the big nerves, the radial, the ulnar, the medial nerve, and little details of all the other nerves that we have. NM3 then, again, we go through the mechanics of playing with that peripheral nerve, and then we go on to the details of each of the nerves within the leg. Femoral nerve, lumbar plexus, and the obturator and the potential, the tibial nerve, all the nerves going into the leg. This is great for your palpatory sense to be more precise, more subtle than you would then be with your more, perhaps, musculoskeletal, or even with the visual techniques that sometimes is a little bit more fascial and bigger in the way that you may address it with your hands. This is so fine and so delicate because compression is going to create symptoms. So you have to be subtle with what you do. And finally, once we have played with the more membranous, so fascial part in NM1, the more peripheral nerves in NM2 and NM3, as we practice the feel of the nerve, practice to see what is the reactivity of the nervous system, how do we feel the nerve buzz, how do we feel the nerve buds, so little rice grains that tells us that there is something particularly in this nerve. Then we go on to the cranial nerves. The cranial nerve class is a very technical, detailed class that explains all of the nerves that runs inside the cranium. And it's amazing what you can achieve because that goes not only in the head, but it runs out into the system. Like the vagus nerve is coming all the way to all of the visceral system, and There is so many details of this class that have profound effect into the body. So we have a lot of things to work on with the nervous system, but the first class is the one that I will happily invite you to come and to see. We have an introduction that I would be happy to see you come and work with me and to try a few things. So we have on the 15th of April, there's a 1 day, like a 4 day situation, 4 hour situation, I mean, where we look into a little bit of detail for the upcoming NM1. So most of all, practically trying a few things that we will expand on in the NM1 class later on in May. So that's the invitation. Come along, play with me in the workshop. Also, we have a little special offer because we have the NM1 class coming in Aarhus in May. I'm inviting you, of course, to come. And there's a little special offer for 500 crowns in discount. There's a discount code here that you can take down and go on to the website and buy the class, of course. So that's a little bit what I wanted to share today. Please let me know if you have any questions today on this on the NM1 or
That was
the
wonderful,
NM in
Kåre.
general.
Thank you so much, Kåre. I'm just gonna end the recording here and we can move on to our Q&A. That was extraordinary.